Hello, everyone. I'm Dr. Azhari Rosman. I'm from the National Heart Institute in Kuala Lumpur. I'm an interventional cardiologist, as are many of you out there. And it's a great honor for me to chair this session together with Prof. Damras. Prof. Damras is, of course, a well-known international interventional cardiologist, and he's a current Senior Director of Cardiology at Bangkok Hospital, Thailand. Together with us, of course, we've got very distinguished group of speakers. Named the first was Prof. Mohaned Egred, and then Dr. Liliya Sorohtey. Dr. Liliya Sorohtey is still yet to join us, and Dr. Tey Yee Sin. We'll introduce them one at a time in a short while. But our session today is, of course, from about 4 o'clock, well, our time at least anyway, for about 1 hour, 45 minutes. And then subsequently, we'll have all the questions on the chat box for all of you to forward any of your comments, or we welcome, of course, questions. So, and I'd like to thank, of course, the people who have made this all possible, the Rosman people, and I think we thank them for this new addition in our interventional cardiology armamentarium, which is the POT balloon. So with that, I'd like to first introduce Prof. Damras to invite him in his presentation for the first case, which is the POT left main PCI. Prof. Damras, thank you for joining us, and over to you.
Yeah, thank you very much, all the faculty for this symposium. Thank you, the committee, for inviting me. My case today, I'll present my case. Okay, can you see my slide, right?
Yes, I can see a slide.
Okay, so this is a simple case, a 59-year-old man, impaired glucose tolerance, hypertension, hypercholesterol as usual, non-smoker with history of sarcoidosis. He has worsened angina for 1 or 2 months before this the investigation, but he had previous 6 session PCI, 6 times. So the first time was done in 2009. The month and date could not be retrieved. The second one was 2014. The third one is 2019 July with patent in-stent mid-RCA, in-stent RPD. There was in-stent restenosis on mid-circumflex and in-stent restenosis on mid-LAD. It was treated in 2019. And again, in November, he came back, patent in-stent mid-LAD and circumflex, but new progressive stenosis, proximal LAD before the stent, and in-stent restenosis type 3 at RPD, and stenosis as Ostial RPD. So at that time, 2019, he had OCT guided PCI at proximal LAD. On that the event, the MLA from OCT was only 2.8 millimeter. So superflex cruise 3.5 by 16 was implanted, and post-inflation by 3.75 by 14 and 28 atmosphere. And balloon angioplasty alone at Ostial RPD and in-stent the restenosis type 3 at mid-RPD. No stent was implanted. 2020, he came back for stress echo. His result was good. EF 70 could be increased to 80%. And 2021, he started to receive Repatha injection for unmet target LDL. After Repatha, his LDL went down to 21 mg per deciliter. And 2021 November, again, dopamine stress echo showed negative, no wall motion abnormality, but he has chest pain. So the 5th angiogram PCI was done on the day later, 2021 November. And the results show progressive in-stent restenosis type 3 at distal RCA involving the Ostial RPD 010 Medina, and new tandem stenosis proximal RCA, patent in-stent proximal LAD and mid-circumflex, suspected Ostial LAD. So we just treat him except the Ostial LAD. 2023, that means around 1.5 years later, in April. He came back because of worsening angina and re-angiogram, patent instant the whole RCA. That we are afraid that the RCA may be closed, but it's still patent. And RPD, instant restenosis type 3 on circumflex, 54% ostial LED stenosis by QCA, no PCI done. At this time, it was after 5th PCI, I turned down PCI, and I consult the heart team approach for cabbage. But after I turned down this PCI, the patient came back and declined cabbage and insist to have PCI done on LDL left main. I tried to search from our friend, from Rosley, from Michael Lee from Hong Kong, from Azhari Rangka from Malaysia, to see that is there any dedicated bifurcation stent like BioSlim? Because we saw from the article result of BioSlim for dedicated stent that it should be very good, but we could not find. We contact Polish doctor, BioSlim was from Poland. We tried to contact them, but they refused to send the stent for us. They said they need a learning curve. So what should I do? This is number 6 PCI for ostial LED, and the result may be difficult or may be simple. It is 010 Medina, and this angiogram was done on June 2023. That was around 4 months ago. So this was angiogram freeze frame. It was the small ostial LED. When you look at the mid LED a little bit more distally, the mid LED is larger. It's better in patency and better in caliber. Ostial LED left main and circumflex is okay. So this was QCA done. The MLD, lumen diameter, and vessel sizing has been done. The stenosis diameter is 1.71. The maximal diameter was 4.06 on the left main. And the percent stenosis is 52% from the QCA. And stent length is around 10.8. And expected diameter is 3.6. So this is the case that I'm going to show. It's not difficult, but show you that POT PCI will help when you need a very short, and try to avoid the carina, try to avoid the ostial LED that the big balloon can create perforation. So IVAS has been put down. I'll show you do this the IVAS run. So this IVAS run was run from the mid LED segment. This is in the stent. You can see that the previous stent is not well expanded to the EM area, not so well expanded, and slowly the stent has been pulled back to the ostial part. You see the ostial LED later and also the side branch for circumflex. I did not use OCT because of the short left main in this case. So this is pulled back. Here, this is ostial LED. Okay, this is all the LED, and this is circumflex. Okay, that is the IVAS run. And on this frame, you can see this frame that the MLA is around 4.15 millimeter. I draw the yellow line just to show you the MLA. On above at 12 o'clock is fibrotic plaque, and this is something like the low attenuation. It may be because of calcium part on this one, or it is lipid. And this is the external elastic membrane. This is also, and this is circumflex. And the EM area around the EM is around 14.54 millimeter, square millimeter. So what we do, we put a 4/12 NC sprinter and we dilate first. This is the freeze frame to see the balloon inflation. You can see that the balloon marker and the shoulder of the balloon is quite long, a little bit longer than 1 millimeter on each side. And this is after balloon angioplasty. You can see that there is some linear dissection of the ostial part. Short left main circumflex is still okay. So we follow by stent placement, and because of IVUS measurement and also QCA, we place a 4/22 resolute onyx to near the ostial part of the left main. Stent was placed to view on the spider view and on the PA caudal view. And you can see that the stent was overlapped to the previous stent size. And this is how the balloon inflation stent has been deployed. 4/22 resolute onyx. And this is initial deployment. You can see that there is a dog bone at the ostial LED, and slowly we increase the balloon size. And this is after fully stent deployment. And after fully stent deployment, we do the post-stent inflation by NC balloon. Note again the balloon marker. This is balloon marker and this tip of the balloon shoulder. The tip of balloon to the marker is a bit long, maybe longer than 1 millimeter, but we do post-inflation according to the ostial LED first. So this is a 3.5 balloon. And after stent deployment, this is the IVUS after stent deployment. Again, you can see that on this side, there is still unexpanded on the 3 o'clock flow clock. And the stent here is now opposed to the vessel wall, except on this area that is not well expanded because of the rigid side. This is on the circumflex side. You can see that at the carina, the stent is a little bit floating. I show you a little bit slowly back here. Okay, you can see that this is the left main. You can see that the stent is still not opposed to the vessel wall. It's floating around here. So this is my arrow to show you that this is the stent and this is the left main area. Here is okay. This spot is nearly opposed. This is nearly opposed except this one. So we have to do POT because of the stent is floating on the left main. So this is ostial LED. Again, this is the LED carina. On this side is circumflex. And this is left main body. The stent is floating. And the gap should be around more than 300 micron, maybe 260 micron by IVUS. So what we do next, just simple. I pick up the 5/6 pot balloon, 5/6, just at the carina. I try to not introduce this balloon into the ostial LED because it may be perforation. And look at the beauty of this pot PCI balloon. You can see that there is a marker and the balloon shoulder is nearly square and is allowed 0.5 or 0.6 millimeter according to the manufacturing brochure that tells you exactly. And now pot PCI balloon is my workhorse for pot. And it's guaranteed that I have never seen any balloon that have the balloon shoulder and marker more than 0.5. What does it prove? It proves that the QC, quality control of the factory, is quite well. We learned from the past, we learned from the Euro bifurcation group that they suggest pot balloon for NC acute force and NC track. But in my experience, the QC, the quality control of NC acute force, was not as they mentioned. We saw quite a lot number, but not ever seen by pot PCI. So I am very lucky that we have the pot PCI balloon on my shelf, and we pick up the 5/0 and dilate from 3.5 by 4/2 by 22 resolute onyx. So it is 1 millimeter larger. And this, after I do POT, I do again IVAS again. So I'll show you the picture of the IVAS. But before I show you IVAS, I pass the Y to the circumflex. You can note that this is the previous stand on the circumflex. So the Y is feel the FC, and it went down very easy. And after the Y went down, this is the NC balloon that I park on the LED and pass the balloon to the circumflex first to open the strut of the left main. And then this is the T5/9 NC balloon. The balloon that pull back the balloon to do more balloon inflation on the circumflex strut near in the left main, and then pass the NC 4/12 and T5/9 for the kissing. I cannot use the 5/0/6 pot with this T5/9 because we use only 6 French guiding catheter. And we pull back again to do a little bit more proximal kissing. So 4/12 on the LED left main, T5/9 for the left main circumflex, or NC balloon. And this is post-balloon inflation. Quite beautiful. And this is spider view. This is the left main. And this is IVAS after POT. So again, you can see that there is some rigid plug that the stent was not well expanded. We try to open it up, but it's just like that. And this is after POT. This, you can see the stent on the left main here is the stent on the left main. I'll show you back a little bit slowly. So this is stent on the left main. It's open better than on the previous one.
Mm.
When I scroll back a little bit distally to the Ostial LED. So this is carina. This is the Y from the circumflex that's coming in on the 9 o'clock. This is circumflex Y. And this is the Ostial LED. When I go back a little bit distally, this is the Ostial LED, the true Ostial LED. And what do we measure? What we do measure on the Ostial LED on the left main carina and the left main body. The MSA on the Ostial LED increased to 11.74 square millimeter, and stent cross-section area on the LED distally is 8.45, where I show you that there is a plug that resistant to balloon inflation. We don't have OPN balloon to open it, but we accept because it's 8.45, and the stent cross-section area on the left main is 19.5 square millimeter. So in summary, for taper vessel such as Ostial LED and left main, the left main is also always large, and stent size choice is the distal reference vessel, and need proximal optimization technique to oppose or expand the stent related to the left main, and POT PCI is encouraging. It avoid the protrusion into the LED, caution perforation, dissection at the edge. And up to date, 4.8 months interval, he is very well. Thank you very much for your attention. That's my last slide.
Thank you very much, Prof. Damras. It's a very elegant display of a very complicated history with multiple stenosis and recurrent. So what have precautions have you undertaken in order to try and shall we say ensure that this patient doesn't come in with another restenosis or de novo lesion? I mean, is there any other risk factors that you need to do, or anything else that you could be doing presently in order to avoid this arthropath?
Yeah, for this particular lesion, like Ostial LED and left main, when we achieve MLA of larger than 5 millimeter, 5 square millimeter, it should guarantee. And if there is no inflow and outflow obstruction, and the stent is not is well opposed, oppose and expand, so there is very, very low risk of the in-stent restenosis that come later. And if you look at the previous 5 PCI case, it take time. I mean, from 2009 to 2021, this are 12 years for 5 PCI. And I think it should be okay. But I admit that I'm the surrender. I convinced him to do bypass. Okay, please go to our surgeon. I will not do to you anymore, except I can find the dedicated stent. So I call Michael Lee, I call Azhari Rangka, I call many persons that if they have any bioslim in their stock, they can use, but there's no. So I have to do this.
All right. Thank you very much. Thank you very much for that nice case. I'd like to invite any comments from the audience or from any of our panelists to about this case.
Yeah. Can I just? I mean, for me, this case is unfortunate, but that shows you the importance of making sure that your first approach and the first procedure you do is done correctly. We live in a time where the stents are excellent, so not every undersized or underexpanded stent is going to cause a problem. However, every time we see a problem with the stent, it's usually undersized or underexpanded. And I think this kind of shows you the meticulous approach that Professor Damras has done by imaging, by making sure the post-dilatation is done, there's no under-deployment, there's no under-expansion, and that will increase the chances of this stent being very good on the long term. Of course, there's no guarantee, because don't forget, this is the disease process itself. But we don't help it by just not doing our procedure perfectly. Absolutely. We should aim for the ideal approach guided by intravascular ultrasound to make sure that you size correctly and you kind of optimize correctly. And then, of course, you treat the risk factors, and hopefully that will be the best thing for the patient.
Thank you very much. And I must apologize for getting your name, Dr. Prof. Mohaned, not Mohammed. So my apologies to you.
It's okay. That's
at a glance.
It is Mohaned, yes, with an N. That's all right.
Once again, thank you very much for that comment. Anybody in the audience perhaps has any comments?
It is, yes.
So, Dr. Tey, any comments on the pot balloon, your experience using it so far?
Prof. Damras has demonstrated a very good optimization of the left main with IVUS ultrasound guidance, because the left main is so short. So if you are using the longer balloon, you might causing a lot of a carina shift and causing the future ostial circumflex stenosis, which I will show you the case later on, and how we use the pot balloon after that and maintain the carina is not being shifted to either left LAD or the LCX.
All right. Okay, thank you very much for the comment, Tey. So I think we've got to move on. So I'll present my case now, which is similar somewhat to Prof. Damras' case. It involves the left main. If I could just share my slide. This is a de novo lesion, actually. It's not slide share. Just get that slide share. It's up. Okay, share screen. So, can you see the slide?
Yes, I can see the slide.
Okay, so I think the idea of again this presentation is just to look at the concept of see, prepare, and treat, and the use of pot balloon and preparation techniques for an LAD ostial lesion, and of course to discuss about optimal stent deployment in this individual, who is unfortunately a youngish individual, 57-year-old. He's got hypertension, diabetes, and dyslipidemia. He's got intermittent chest discomfort. And his investigations include the 2D echocardiogram, which showed good LV function. And he had a CT scan done, which is early this year, which showed a calcium score involving the LAD primarily with calcified ostial LAD lesion. Circumflex has got some plaque, but minimal otherwise, and the RCA showed minimal proximal stenosis, not immediately obvious on the angiogram, as you'll see later on. The HbA1c is about 6.9. For diabetics, reasonable, and sugars, and of course the LDL. EGFR is good. So this is the LAD lesion, and I just limited to a few views, but this is the epicardial view. But you can see there is an epicaudal view, which is, you can see that stenosis, which is not immediately obvious in initial angiogram. This is using a 5 French octitop. And so there's some disease in the LAD. So the idea is to use, because of the age, try and minimize the amount of metal that we need to use and try and minimize any barotrauma to the vessels. So hence the approach that I've actually elected to adopt is a crossover stent for this patient involving the left main and the LAD, because the plaque seems to extend into the LMS. And you can see that there is also extension of that disease into the left main from this picture. Now, so this is the right coronary artery. You can see that it's angiographically quite okay, although there are some minimal stenosis on the minimal disease on the MS CT angiogram, but otherwise it's a dominant, very large right coronary artery. So I think there's initially the need to look at how severe this lesion is on some functional assessment. We have at our lab the QFR, and of course the calcium, how much calcium there is. Does it tally with your calcium MSCT? And of course, if you use IVUS or if you have stent boost, a very simple way of looking at the calcium distribution, which we find quite useful. And of course, when we talk about next stage is preparation, reassessment, and choice. So these are the overview of what we're going to discuss about. And of course, we'll talk about the lesion severity. You can see that on QFR, it's about 0.69, which is significant, less than 0.8 significant. You can see with the new version 2 of our QFR, you can see that there is good contouring of the lesion. As long as you get orthogonal views, you get good contouring, and you can measure the degree of stenosis reasonably well on the QFR. So ours is about 0.69. So the IVUS measurement here, you can see on our IVUS is the IVUS pullback. The vessel is quite large. It's not something that you obviously recognize or appreciate on the epicardial view earlier on, but the measurement distally is about 4.3, 4.4 thereabouts. And this is the pullback on the left panel here. You can see that as you approach proximally, you can start seeing the lesion. There's some very dense fibrous and some areas of fibrocalcific distribution as we move on proximally. And the total length is about 20 millimeters in terms of disease segment. There's a circumflex coming through. You can see the left main coming out. And the stenosis, the MLA of the LAD is about 3 millimeters. Plaque morphology has got calcium on 2 quadrants. You can see in the lower panel in a red arrow upwards. And I thought that perhaps this is the best we can do with the balloon. Vessel size is big, as you can see. It's about at least 4 to 4.5 in terms of vessel diameter. And this is the left main area which has got some disease. Oops, put here. Let me just see whether we can go back. Can you see the slide? Hold on a minute. Just see where this. I can see, but I've lost my picture from my end. Wait. Okay. Okay. So and this is the left the circumflex area. Circumflex area to show that not much disease on the proximal circumflex area. Again, MLA is about 11 millimeters squared with about 32% only slug plug, but the vessel size is quite big, as you would expect from the size of the right coronary artery. So that's the circumflex area itself, and I thought maybe we could get away with just stenting crossover into the left main and into the LED. So I think the intervention strategy that I've decided on is about to do a crossover stent with the plaque burden being extending into the left main. That seems a reasonable approach. But there is also segmental planar calcification, which I think could be tackled with scoring balloons and, of course, NC balloon, and then optimization with the pot balloon. It is a fairly short left main vessel, as you can see. And of course, the next issue is, of course, due to the density of the plug itself, maybe an option would be use a good stent, which is in our case, the Megatron Boston Synergy is good, got a good rigid structure, can expand to a very big size. And of course, radial stent is very good from our experience. Let's have a look at the debulking, how it went. So the approach is actually to, you can see the plug is extending from LED into the left main. I put in a couple of wires into the circumflex as well as the LED. And this is the balloon with the wedge 3.5, went up to 12, 14, and subsequently higher pressures. There is some wasting, you can appreciate the mid segment here, but this wasting, as you can see later, is actually quite recalcitrant, not easy to remove. There is a shadow you can see of that calcification here, and consistent with the IVUS finding. And I increased the size of the balloon to a 4O15, again 12 atmospheres to 22 atmospheres. But there is still some residual calcification, residual plaque. There is a fair amount of recoil, although the balloon was fully expanded. You can see here using the NC balloon. We moved up to a Wolverine as well, 4O 15, and this was again at 12 to 20 atmospheres. Again, you can see that there is some residual recoil. So then again, now you have the choice of having to use bigger balloons, and but if I did, there's always, now that the balloon is sized according to the vessel as per our IVUS, going to a higher stent or device, a higher balloon or cutting balloon might cause a dissection. So I thought a good stent choice, which has good radial strength and good support for the vessel, is a better option rather than trying to go higher and higher in terms of pressure or higher in terms of size of the balloon or scoring balloon. So this is a Megatron Synergy 4.0 times 20 millimeters. Remember the length is about 20 at the most, and with the short left main, and of course the crossover stent. This is the stent deployed on the left main itself into the LED, and the short protrusion from the left main ostium into the LED. And of course, this is the pot balloon. You can see the pot balloon itself is positioned very nicely there. It's a very good, has got very good markers. Sorry, let's go back to the, so that's the pot balloon and the stand. You can see there's some minimal suboptimal area just at the ostium because of the heavy plaque burden. And again, this is the infographics of your pot balloon. You can see that it actually shows it has a very good shoulder, very short shoulder. It goes into the ostium of the side branch rather than causing barotrauma to extended part beyond the marker itself. And this is the marker you can appreciate there. So, and it has a very good profile. It inflates with a fairly truncated shoulder. And this is the pot balloon again, and you can see, as Prof. Damras mentioned earlier on, very short sort of linear edge of the stand of the balloon onto the stent. And this is the apicaudal view with the 4.5 diameter, 6 millimeter balloon deployed at 12 atmospheres, and subsequently with a wire crossover. So again, after a pot balloon, we cross over onto the side branch, as is the normal practice, and subsequently post-inflation with a NC balloon with a 4.0 50 millimeters at 18 atmospheres. This is the final result. You can see the nice circumferential area in the left main with the MSA of about 12 millimeters squared. And this is our pullback. On the left, you can see that this is the distal LAD, and as you pull back, there are some specks of calcification at about 3 o'clock or 9 o'clock, and this is the stent itself, and you can see it's well expanded. Very circumferential shape, very strong radial strength of the megatron. And here again, you can appreciate that there is an area of plaque density here. And this is the left, this is the Ostial LAD. So this is the final view. You can see that there is some narrowing there, but I didn't elect for final kissing balloon. You can see that the angiogram looks okay. We did the QFR measurement, and this is our QFR measurement of the LAD, which is 0.91. And this is the QFR value of the circumflex area with no delta in terms of your stenotic area, and well expanded stent. So I think the learning points of this is that the very short pot balloon itself gives you a very nice short full expansion of the LAD left main area, and therefore good expansion into the area without shoulder or damage into the proximal left main. So I think most important is to assess the severity of your stenosis and subsequently decide on what mode of preparation of plaque. In this case, we've used a scoring balloon with a Wolverine as well as the Scoreflex balloon, and subsequently, even with a residual stenosis, I think once you've got a good strut, it's a good result. If you've got a good balloon proximally and you've got a good NC balloon to optimize your results. So that's the case that I presented for a short left main LAD lesion with the use of the pot balloon into the left main. Thank you very much.
Yeah, very great case. Great case. I see that it's very rigid, the ostial LAD and left main, because when the stent was expanded, it still see the non-circular contour from IVUS. And yeah, but I don't know. Do you dare to use the OPN balloon to open it further, because you use the Megatron? Megatron is very rigid and very strong radial force.
Yeah, that's an option, I think, if you want to use, but I think there will probably be the risk that I think, if the results are reasonable, I would elect to just accept that, and I think an OPN would be a good option, except that, as I mentioned earlier on, there's a lot of plaque there, and I think some of that plaque will still persist with the risk of perforation. I think the only fear we have about the OPN balloon is because there are areas of calcification, there is a risk of perforation, in which case it's probably something one has to consider. And yeah, we've had instances.
Yeah, I think that's absolutely correct. So.
Can I sorry, please.
Yeah, it's a very good result at the end, and sometimes perfection. Oh, sorry, I said it's excellent result at the end, and sometimes perfection is the enemy of good. I mean, you achieve a very good final result, cross-sectional area. There is an eccentric, looks also deep calcium that you hardly see on IVUS, because there was all that blocked with the IVUS. So,
right.
And maybe fibrotic tissue. But I think ultimately it's a good result at the end.
Yeah. That's one of the things that we're beginning to appreciate nowadays in our younger patients. The concern is that these are the sort of individuals who have this very bad atherosclerotic disease involving not just fibrous but calcium areas. The problem is, of course, we have not every facility in Malaysia has got IVUS. So if you look at just angiographic, you can appreciate that there's a lot of information that you're actually missing out from just the size and the amount of calcium distribution, the amount of plaque. So I wonder, as the cases become more and increasingly more complicated in the sense that, the plaques are not quite what it used to be and the patients are younger, one has to try and balance out how aggressive that we need to be, and at the same time use the imaging and functional assessments that we now have available. In other words, because of the lesions and the patients who have these lesions, we need some precision medicine in the future, and I think that's very important to appreciate. In the past, we used to look at it angiographically; it's great, and that's fine. But now we know that some lesions are actually quite misleading angiographically. Right. We have no questions from the audience so far. So now I think we'd like to move on to the next case, which is Dr. Liliya. Is Dr. Liliya with us?
Yes, I am with you.
Dr. Liliya, welcome. We didn't have an opportunity to welcome you earlier on. Dr. Liliya is the head of the angiography department and interventional cardiologist at the Ukrainian Polish Heart Institute in Lviv. Dr. Liliya, we'd like to welcome you to share your case.
I am sharing the...
I can see your screen.
Yeah. I'm sharing the screen. Do you see the screen?
Yes, thank you.
Okay. Good morning and good evening for everyone. I am Liliya Sorohtey, and I am an interventional cardiologist and the head of the angiographic department of the Ukrainian Polish Heart Center Lviv. First of all, I want to thank you for the opportunity to participate in this meeting. It is a great honor for me. And my case is also about the Ostial LAD. And this is, and we see that this problem is very important because the Ostial LAD is one of the type of a bifurcation lesion, Medina 010. And in the most cases, it is difficult to cover the ostium. That's why we have to put stent from the left main to the LAD. And while our stent is tubular and the diameter of this is the same in the whole length, it is not the same at the vessel. The diameter of the proximal part of main branch is larger than at the distal part and the side branch, and we always use this formula to know the diameter of the main branch. And we have to choose the diameter of stent due to the distal diameter. That's why we need proximal optimization. And the proximal optimization is the mandatory step of any bifurcation stenting now. And it helps us to avoid malposition of the stent in the proximal segment, understand rewiring, and help us to follow the distal strut when we're rewiring, and allow a good ostial side branch scaffolding with stent. So let me introduce my case. The 78-year-old woman with hypertension, dyslipidemia, history of myocardial infarction, was admitted to our clinic with non-ST elevation myocardial infarction. She has left bundle branch block, not new, and reduced ejection fraction. And due to the tendency to the hypotension and the ongoing chest pain, the urgent coronarography was performed. And we have seen the left dominance, the chronic total occlusion of recessive right coronary artery. And here we have a very complex lesion with 3 bifurcation, here, here, and here, and here. And we decide there is severe stenosis at the ostium of LAD, severe stenosis at the proximal and middle part of the LAD, and the distal bifurcation stenosis with the second diagonal. We identify this stenosis as the culprit lesion. There's also bifurcation lesion, and perform the primary PCR here. With a good result, we perform provisional stenting with proximal optimization. Now we have evidence for the benefit of the complete revascularization at the same hospitalization. So the next day we discussed this case with the heart team, and we decided to perform a PCI of the LAD, not to touch the recessive right coronary artery. Our plan was to do IVUS, and then we will treat the distal bifurcation with stents over with DCB, and put and stent from LM from left main to prox LAD. We perform IVUS, and we saw that the distal LAD is very tiny. And that's why we decided to treat the distal bifurcation with DCB. The result was not bad. Here you can see the result. And then we proceeded to provisional left main LAD stenting. As you can see, the lesion is very complex. We have here, because we have landing zone for our distal stent, and the tiny stenosis of the proximal and the mid LAD, the tiny here, and the tiny stenosis, the LAD just near the bifurcation. Also, the left main is long and have a different diameter, and a moderate lesion here and here. Here it is, the diameter is more, we have seen. That's why we didn't want to cover the whole left main, because of the length of this stenosis, and enough MLA in the, this is the proximal part here of the left main, and this is the distal part. So we want to leave only a minimal part of stent like this here, which would be sufficient for proximal optimization. We put the wire from the diagonal branch to the circ, then we predilate, and after this we perform POT. Before this we lost the wire from the circ, and we have seen that then we rewired after POT. The POT was done with dedicated balloon 4.5 to 6 with 18 atmosphere. And After this, we saw that our wire is not intraluminal at the beginning, and then it came to the lumen, and we have seen that stent was underexpanded at the prox LED and in the ostium. That's why we post-dilate the prox LED with 3.5 NC balloon and the ostium with 3.7, and perform another port with a larger balloon, 5 to 6. We position the balloon just near the carina and check into projection. Also, we check by a little amount of contrast to be sure that we are in a good position. And after this, we perform port from distal to the proximal. And after this, final IVUS showed us the well-exposed stent. This is proximal LAD. This is LAD, just the ostium of LAD, and we can see some struts that cover the ostium of circ, and this is left main. We have seen that stent is not well posed. And also we got this not bad angiography result here and here without compromising of circ and a good distal flow. So on the 7th day, the patient was discharged with improving ejection fraction and without angina. And so we have to do properly proximal optimization. It is the elective and very important part of bifurcation stenting. And so we have to have the dedicated balloons for this. And this port balloon with its short shoulders provides better position on the carina and reduce the shifting of the carina and avoid elongations. That is very important sometimes when the left main is short. And the use of the port balloon for proximal optimization simplifies the procedure and improve the final results. Thank you for your attention.
Thank you very much, Prof. Liliya. That was a very nice case. I mean, the final results quite impressive compared to when you started that vessels, those vessels. Can I welcome any comments or questions from the audience or any of the panelists?
It's a great case, great case.
Mohaned, yeah.
I have the questions to the panel. In this case, I couldn't deliver this port balloon to the circ. It was very hard. I think it is also because of these short shoulders. Maybe you have some tips and tricks for this problem?
Any comments?
Sorry, you said you couldn't do what?
I couldn't deliver this port balloon. Yeah, delivered the port balloon to the circ through this angle at the first step of the procedure when we performed the primary PCR for circ.
Yeah, I mean, I suppose this is not surprising because it's quite short. And it is a non-compliant balloon to a certain degree, so it is a bit thick and a bit difficult to. So maybe a body wire just to deflect it, because it doesn't bend as if it's a longer balloon. I think it's the short nature of this balloon and the material of it makes it difficult. Longer balloon probably would have gone, or a body wire would have helped you to deflect it and take it there. Because I've had this before and ended up using a body wire and it just went.
Thank you, Dr. Mohaned. So, Dr. Mohaned, I actually took your slot earlier on, which is Dr. Mohaned's case, which is the clinical cases with pot balloon. Dr. Mohaned, would you like to present your case?
Oh, it's okay. So I'll share my screen with you guys. Can you see my slides?
Yes.
Okay, good. Well, thank you very much, first of all, for the opportunity and for the nice meeting and informative. I had to change the cases, to be honest, this morning because I had IVUS and another one OCT, but for some reason I could not play the images. So I kind of chose two cases to present today, and also to show where I think the pot balloon comes in. There has been illustrated in the previous cases, particularly in bifurcation, but also there's another area I always see it, which allows you to reduce the amount of metal in the artery and use the post-dilatation in a precision and really controlled manner. These are my conflict of interest. So the first case, so I'm going to focus more on the use of the pot balloon rather than tell you about the details of the procedure that much. There will be some angiogram, but not much. So 67 years old, previous MI, primary PCI to the RCA. And there was identified disease in the circumflex as well as the LAD. He has a history of hypertension and dyslipidemia. And he was symptomatic with ischemia on MPS. So this was his diagnostic angiogram. As you could see that they were going just for, so here, the circumflex does have some plaque disease, and when I'll just keep that playing. When we assessed this, the pressure wire was negative, so we did not need to do it. So the main focus here became on this LAD and diagonal bifurcation. You could see that looks like a type A LAD, which is North American call it type A, where the diagonal is almost as big as the LAD itself. So both arteries were wired and pre-dilated, and then a stent was inserted into the diagonal, as you could see in the screen on the right. Of course, my plan was not to make this a complicated bifurcation lesion because the ostial diagonal seemed to be free of disease, and on IVUS it was free of disease. Apologies again, I could not run the IVUS, just for some reason I couldn't integrate it into the maybe because it's on a memory stick. Anyway, so the diagonal was stented and post dilated. IVUS showed good result, as you could see in here, post dilated the ostium. And now we're ready and of course you always elect to treat the side branch, so you don't have to go through the stent struts if you're not going to do a kind of dedicated bifurcation technique. So this is not the bifurcation as such. And then this is after the inflating the stent, putting the stent in the diagonal, post dilatation and pre-dilatation of the LAD. So it's ready for a stent insertion, as you could see. And here we insert the stent into the LAD. So the idea was, because the proximal LAD was quite normal, did not show much disease, is to make the amount of metal in that proximal LAD as little as possible. And of course, when you try to do this, you're always going to be faced with the problem of post-dilatation and doing the pot, because the shortest balloon we have is the 6 millimeter. And of course, with the normal 6 millimeter balloon, as mentioned in the previous talks, there is shoulder on them. So if you could first of all distort the bifurcation itself, and also you might end up causing a problem with the proximal part of the artery, when the shoulder could easily cause a dissection of the proximal part. So here it became important to make sure that the stent is positioned in a place where I could use a 6 millimeter balloon without being concerned about the balloon coming back to the proximal LAD and causing problem. So this was the stent inserted, and this is how, let's run this again. Oh, that's not, yeah, I'm not sure why I'm having this difficulty today, but anyway, let's just continue here. So here, this is where I see the pot balloon is quite an important tool here, because you take any other balloon, this is the pot balloon in the proximal LAD. because it's 6 millimeter and because I don't worry too much about the shoulder, if I position it correctly in the proximal part of the LAD, then I think I have no concern about causing any damage to the proximal part of the LAD. And in the same token, I will not be distorting the bifurcation itself. So we took the pot balloon. This was a 4O. It's an LAD. The stent was 4O, deployed at low pressure because the distal LAD wasn't as big. And then we post dilated proximally. Then we took the pot balloon, and the pot balloon allowed me, I don't know if this is, I'm not sure why this is not. Let me just go back and come back again to this. So here we go. You could see that the pot balloon, very, very little shoulders on them. So the proximal LAD will be, or the stent will be optimized, will be well deployed, well opposed. And in the same token, I have no worry about damaging the proximal part of the LAD. And this can apply to any artery. So I think one of the important use of the pot balloon are these cases. I was able to keep the metal in the LAD to a minimum. And in the same token, I knew that I could optimize this artery and the stent deployment without any concern. And here is the final result. Excellent opposition. And this was confirmed by an IVUS again, as I said. And you could see that the bifurcation is intact. The diagonal is open, all deployed, all well, and the results was excellent. Follow-up of the patient a few months later showed well, actually 2 months later, we saw him just recently. This was absolutely fine because this was done in August. So this is one of the most important indication in my mind to using the pot balloon. Where I'm concerned, I don't want to be causing any damage to the artery, and you could use it in the LAD, in the circ, whatever it is that you need to use it. Now, the second case is similar to what's been presented in the left main stem. Again, you're trying to leave the amount of metal as little as possible. And when you are doing the pot or the post dilatation, particularly if you have done a dedicated bifurcation stenting, whether it's a kilot or whether it's a DK crush or any of the other technique. So getting the post dilatation correct and positioning the balloon correctly could have an impact on the outcome and the results. So this was a 78 years old female, a previous CVA, good recovery, not much impairment. She has hypertension and hypothyroidism. The LV was impaired, and she was admitted as an acute coronary syndrome. This is her angiogram. As you could see that there's some distal left main disease into some plaque disease in the LAD, and the circumflex has a significant lesion in the, this is just a big OM that bifurcation that has a significant narrowing proximally. Apologies, I don't know why this is doing. My slides are not playing very well. It keeps telling me my internet connection is unstable. I'm not sure why, but there we go. So you could see that the severe stenosis in the OM as well as the left main stem. Again, this was assessed by IVUS, and the left main cross-sectional area was 4.8. So it's quite significant. There was the disease extending to the ostial LAD, but the ostial circumflex, it was not as bad, very minor atheroma, and the cross-sectional area was 6.8. Again, apology, I can't show you the IVUS because they're not playing. Even this angio is causing me trouble here. So you can see that's the LAD and the circumflex. The circumflex was first wired, and the aim was to treat this area. And this is what we did, pre-dilatation. Again, stented the circumflex. Now, this is just playing havoc here. Apologies. This is so we stented the circumflexor here, and during this delivery of the stent, there was effect on the ostial circumflex. There was a small dissection there, and because we were going to treat the left main stem, this had to be done. I had to stent the ostial circumflex, so I elected to do a kilot technique here. I won't bore you with the details. We stented from the left main into the circumflex, recrossed into the LAD, pre-dilated, and then inserted the second stent in the LAD. And this is I'll go back and come back again. And this is the kissing balloon in the circumflex. Of course, as you could see, the left main stem is quite short. So this has been highlighted again in the previous, and this is an emphasis on the use of the pot balloon. Where can you use it in cases like this? Because it has no shoulders and it is a short, you could easily use it and stop short of the bifurcation, so you do not affect the carina that you have created after your angioplasty. You can see this on the right side. Oh my God, why is this happening? Let me just play these. Because the stent at the left vein is quite short, I took a 5/0 pot balloon, and I know just by angiogram. God. My screen is freezing, you guys. Apologies again, and I don't know why this is happening, but there we go. You can see the pot balloon in the left vein here. It's a 5/06. Sorry?
I can see it. I can see your screen.
Anyway, so 6. Yeah. Is it moving? It's not moving on my side. Is it moving?
No,
it's not.
No, it's not moving. I think it may be the internet.
Just get into an. Okay. I think it is because it tells me it's unstable for some reason, which is something new I haven't had before, but there we go.
We can appreciate the movements.
Anyway, with the left vein. Yeah. If I'm gonna go back and come back to this, see if it'll work. Okay. It's not. Anyway, so the pot balloon, the pot balloon has allowed me to be very precise in stopping for the distal, so I don't affect the carina that I created with the Calot technique. In the same time, also I was able to stop at the proximal part of the stent, so I do not cause any damage to the left main, because the shoulder on the pot balloon, as has been shown, and the schematic demonstration previously from Dr. Azhari was excellent, because it does show you the benefit of this balloon. Any other non-compliant balloon will have a shoulder of 1 millimeter, so it always might have an effect. And often we find when you do a post-dilatation, you keep the dot inside the stent, which means you do not affect the very proximal part of the stent, because the balloon is inside the dot. If you go out, there is always that chance of damaging the artery where there is no metal. So I think this is where the pot balloon comes handy and becomes very important to help with that. So after we did this, I'm going to play this one more time, see if it is playing. It's not. So again, here you could see that the pot balloon has done its trick, 5/06 millimeter. I was away from the bifurcation, so the carina did not get affected. The IVUS demonstrated what we always call the kind of the good outcome with the with Calot, where you see the figure of 8 between the two arteries, and this was the final result for this lady. Now, again, the two areas I see the pot balloon has been highlighted very well in bifurcation, so it's really controlled short. You could stop short of the carina, so you don't cause a carina shift, or you don't cause any impact on the side branch. And if you wanted to keep the metal very short and very little in any artery, you are able to do this by making sure that this balloon stays inside the stent, and the shoulder doesn't, with no shoulder, it does not affect any part of the artery and doesn't cause any dissection or any problem. And I think this is quite an important addition to what we use in our angioplasty and precision angioplasty. Of course, all are guided by imaging, and this is very effective. And this is these are my two cases, and apologies for the kind of stuttering run of these images, but I can't help it. It's the internet doesn't seem to be as good. And thank you very much.
No worries. Thank you very much. Thank you very much for that nice presentation. That's a nice illustration of the staying focused with precision medicine. I think that's the recurring theme, Dr. Mohaned. It's a good illustration of how you've actually used the pot balloon in the Calot technique, and and these are heavy metal kind of procedures. And the shorter it is in terms of longitudinal, the better it is, because as it is, there's a lot of metal in that left main. So the recurring message that I'm getting is that, this pot balloon has enabled us to reduce that metal in the in the proximal segment by about 25%, because previously what we had was maybe the shortest was 8 millimeters, and now it's like 6 millimeters. That's 25%, and that to me is an important reduction. That by itself is quite a big leap. I'd like to invite any comments from the audience if they have any.
Yes.
Okay, there's one question here which says.
Well, there is a question.
Sorry.
Yeah, sure.
Yes. It says, do you think we should have a pot with a 4 millimeter balloon length?
So yeah, there's a question from the audience.
Yes. Question from the audience. Am I missing one question? There's one.
You know what?
There.
If kind of.
Sorry, you're saying?
Yes. So it says, do you think we should have a pot with 4 millimeter balloon length?
Yeah.
I said.
Any comments on that?
The question is, do you think we should have a pot with 4 millimeter balloon? And I think, look, I would say if it is possible, kind of in an engineering and a production way, why not? Because that will allow you, in cases like the LED. Oh, sorry, this is just an alarm test. Nothing to worry about here. Like in the LADs, the first case I presented, if I knew that I had a 4 millimeter balloon, because to my mind, the less metal, the better.
Right.
You know, the less metal in the RT, the better. If we have a pot balloon that's 4 millimeter, then I would have been able to shorten my stent and use that pot balloon. So, but I don't know engineering wise. Of course, engineers are very clever. They could always come up with a solution. But if that's possible, then yeah, why not?
I mean, if it's 4 millimeters diameter and 4 millimeters across, it's practically a sphere, isn't it? I'm not sure how that's going to gel.
That's what I'm saying. Engineering was, I don't know if that will work, but who knows? Incidentally, there is, sorry, just to say, there is a kind of a spheric balloon that is used for kind of flaring the ostiums. I can't, the name escapes me right now, but there is a similar balloon that is just a ball that you use it to flare the ostium. So it's possible.
Okay, very good. Wonderful. Any comments from any of our panelists? There is no other questions from the audience I can see. So, Dr. Liliya, any comments on the cases that we discussed so far, or even your experience on the pot balloon, Dr. Damras and Dr. Tey? Please voice your opinions.
My experience is very small. It is only third my case with this balloon. I think that it is very good for left main, and that's why we need maybe 6 millimeter balloon for this.
Right, totally agree. Dr. Tey, you're going to present the next case anyway,
yes,
so I think
you're most few cases from our experts presentations that how to use this pot balloon, in particular the left main and also the proximal LED. For me, actually, I'm doing quite a number of cases with my consultant as well. So we are quite okay with this pot balloon to optimize the outcome.
All right, thank you. Dr. Damras, your experience in Thailand?
Yeah, for me, when I have to put a stent, we call main across side. Main across side, whatever bifurcation, I will go to my shelf first and to see which size, width, length of the balloon that I have on my shelf. If I have 6, I will put a stent at least 6 millimeter above the carina. If I have 8, I will put a stent 8 millimeter in the carina. Try to first look at your logistic in your stock first before, because sometimes you don't have 6 millimeter balloon.
Yeah,
that is the one way, because before we put a stent, make sure that you have all available in your stock. That's all.
And I think that's emphasizes the importance.
You should have a 4 millimeter balloon then.
Then you can use less metal. Thank you very much, Prof. Damras.
Yes. So if you have a 4, you can use this.
Yeah, you can use a shorter stent. So thank you very much for that comment. I think we will have to move on now. Let's move on to the next case, which is Dr. Tey Yee Sin. Dr. Tey Yee Sin will talk about the case that he has. Dr. Yee Sin is an interventional cardiologist from here, the National Heart Institute of Malaysia. And Dr. Tey, are you okay to present now?
Yes, I'm ready to present. I have shared my slides. Are you able to see my slides here?
Okay.
All right. So I'm Tey from National Heart Institute or Institute Jantung Negara Malaysia. I'm a cardiologist here. So just give me some introduction of these bifurcation lesions that which we commonly deal with in about 15 to 20% of our usual coronary interventions. Regardless of whether it's left main or the non-left main bifurcation, when you need to put a stent across the bifurcation, you have, like what the Dr. Damras will say, that you have to look into your shelf whether what is the minimum length of the stent across at the proximal part above this, beyond these bifurcations lesions. So Prof. Chen Xiaoliang has come up with a very simplified idea to how do you choose whether you proceed with the provisional or the upfront two-stent strategy in the bifurcation stenting of coronary angioplasty. So however, regardless of if you are using a keloid, DK crush, provisional, or proximal optimization is always recommended worldwide in order to optimize the stent and also avoid the coronary shift, as well as this all can help to reduce this the ISR or stent thrombosis if the stent is not well optimized or well posed. So this POT balloon actually just come to Malaysia not long ago. So prior to that, if you're using the other types of the non-compliant balloon, you may have this issue with this coronary shift, as well as this inadequate optimization of this stent proximally. So let me share the case with you. This is a 72-year-old lady with a coronary artery disease who presented to us 3 years ago with a calcified LAD and also severe stenosis at the RCA. So coronary angioplasty was performed with two stents, one at the RCA with a 3048, and the other one is the left main, ostial left main to the proximal LAD 3538 after the orbital atherectomy. And her echocardiogram shows a good EF with an underlying comorbidity, hypertension, and the dyslipidemia. So during that time, we do not have the POT balloon. We use the non-compliant balloons, and this is IVUS imaging guidance. So during the routine follow-up, patient remain asymptomatic. Usually, we will still do this regular stress test despite patient asymptomatic for those who have the left main stenting. And unfortunately, during the stress test at the end of the stage 3 to stage 4, you can see there is a deep ST depression at the inferior lateral. Otherwise, the blood tests are unremarkable. So this is an angiogram that was performed 3 years later. You can see there is a stent from the ostial left main to the proximal LAD, which is a mild ISR. Otherwise, the ostial circumflex lesion, which is a negative, is a severe disease, severe stenosis. LSD stent proximal part is remain patent, and the RCA stent also remain patent. So from here, Medina classification usually is used to describe in the bifurcation lesion, native bifurcation 0,011 or 001 or the 101. In particular, our patient, this is a 001 lesion. It's a very severe stenosis. And what will be our intervention strategies? So before we intervene, we must have some things in our minds that are you going to just drug-coated balloon at these lesions, or are you going to put in the stent? And what are the bifurcation stenting strategy for these patients? Is it the reverse crush or the TAP or the keloid? And how do you prepare the lesions in order to the stents can be well optimized and also posed at these ostial lesions? As usually in this kind of the bifurcation lesion, you always see that ostial circumflex lesions, they have this issue of a negative remodeling, as well as this calcification. So in these patients, we know that we're using the left distal radial approach because of the very good outcome from the previous studies. And this is the balloon tracking, as after we remove this diagnostic catheter, sometimes because of the bands and the spasm, you may need to, when you change to the guiding catheter, you might need some maneuver to handle this. And because of the very tight lesion, the moment that after we put in the balloon, the wire, we push in this semi-compliant balloon, inflate at the 2.515, followed by the wedge scoring balloon 3515, and then we perform the IWAS to see do we need to prepare further. So this is our IWAS from the proximal circumflex to the left mains. The distal lesion size is about 3.75 to 40 with about 1 to 2 quadrants of the calcifications. In particularly, if you look at the ostial circumflex, this is the ostial circumflex. There are about 2 lesions just opposite to this carina, and followed by the left main. The stand are all well opposed. If you look at the longitudinal view, despite after our preparation, you can still see that the carina is being impinged on these circumflex lesions. This is the reason that the patient come back after 3 years with the progression of the lesion at the ostial circumflex becomes severe stenosis. So how do we prepare these lesions? Is it optimized after we prepare with this scoring balloon 3.5 of the 15 at a high pressure? So this is an angle of between the 70 to 90 degree, and the left main area is about 18 mm, and the ostium circumflex is a 3.78 with a 2 quadrant to near 3 quadrant of the calcium, but the length is very short. Thus, by using this scoring balloon is quite adequate, or if you are not happy, we can use this cutting balloon as well. The left main from the ostium to the distal left main, the length is about 7.67. So bear in mind that we need a POT balloon to well optimize after the stenting for these patients in order to maintain the carina at the center and also the patency of the left main. So this patient, the side branch ostial lesion has a very eccentric plug with negative remodeling and the 2 to 3 quadrants of the calcium. And the bifurcation angle, you have to maintain the carina at the centers so that the clinical outcome of this patient will be improved in the futures. So after the preparation lesions, with reference to the distal vessels, we use the drug-eluting stent 4016. This is the reverse keloid technique. And after the deployment, we are using this POT balloon 4.56 mm, of which you can use the distal marker is proximal to this carina. So after that, after we optimization POT balloons at after the first POT, we rewire both LAD and circumflex accordingly, and we optimize the circumflex stand with the non-compliant balloon 4.012 millimeter to the high pressure. And because of using this non-compliant balloon from this circumflex across to the left main, you might cause this LAD, ostial LAD being jailed or being pinched. Thus, we use another 3.5 non-compliant balloon at the proximal LAD and followed by the KISS before we do the POT proximal optimizations. So this is a KISS with a 3.54 at the 12 millimeter, 12 atmosphere, and followed by another 4.56 millimeter at the 20 atmosphere. So this is another pictures that you can see that our POT balloon have a very short shoulder so that the marker can put proximal to this carina and avoid the jailing of this either of the artery. So post procedures, the stand is well opposed and there is no distal stand edge dissections and the ostial circumflex are well opened up. So this is our final result with the different view can show that our carina being maintained and the stand are all patterns and also there's no distal stand edge dissections. So let me show you the pictures of these our patients. Here's the left main area of the 15 at the mid body. The ostial LAD is about 9.04 and our ostial circ is about 6.4 from the previously 3.2 after the preparations. And if you look at the longitudinal view, there's no any carina shift and the carina at this ostial LAD and also circumflex maintained well maintained. And according to this Dr. Kang Assam Medical Center criteria, if you can maintain the ostial circ LAD and left main to the minimum area of this, it can reduce the risk of this RSR in the future. So in summary, the proximal optimization technique is necessary in optimization of this patient clinical outcome because it can avoid the carina shift reduce the chance of the ostial lesion ISR in the future. And also you can concentrate going up the high pressure at the focal area to ensure the stent are well opposed. And the lesion preparation and intracoronary imaging in this patient also key to improve the short and the long-term outcome. Thank you.
Thank you very much, Tey. That was a very nice, very sequential and well-covered topic. You managed to get very good results at the end of the day, and the ostium has always been a challenge. You know, any comments from anyone?
That's a very good case. Very good case for you to do the reverse culotte, and then they'll do POT, and you have to do POT on both in the new circumflex stent and the old the left main LAD. You have to do both POT.
So thank you, Prof. Damras. I was just thinking at the back of my mind, you know, a lot of these lesions nowadays, as you've seen, I mean, we've been thinking that, you know, the best is like a very good results, and now nowadays, because of the lesions themselves, we have to accept some degree of angiographically at least some evidence of plaque, you know, under, if you like, under full expansion, if you like, on the angiogram. So what is your comment on that? You know, it's just not possible to get the sort of results that you dream of about anyway. And invariably, it seems to be okay for the patient. But just to, you know, pose a question to the panelists, you know, how much of a residual are you willing to accept? You know, considering that some lesions are just difficult to actually open up. I know we have IVL, and some have resorted to IVL after the stent deployment because they're not so well expanded, and so on and so forth. But I mean, what is your comfort level to say that, you know, this amount of block fibrocalcific or dense distribution or whatever, you know, is okay with me as long as the, you know, IVUS or OCT is acceptable? Can you comment from Tey, Damras, Dr. Liliya, Mohaned?
Yeah, what I'm the mostly afraid is the big calcium nodule. The calcium nodule is the one that is very difficult to treat. And for the taper vessel, I mean, in the past, my champion stent is still exposition S, where when we don't have the big pot balloon, I prefer to use the exposition S for the small LED and big left main. But for calcium nodule is the one thing that you never success, and there is no how to select the device to conquer this calcium nodule, especially the volcanic calcium nodule. Who else can tell your tips and trick?
Thank you very much. That's a very important comment. But it may not be.
My take is on this.
Dr. Manas, yes.
Sorry.
Carry on. Yeah.
Just what I was going to say. My take on this is it's a very interesting question. What level of comfort? If you look what's happening currently, there's a paradigm shift to using drug-eluting balloon. And drug-eluting balloon, you never get 100% lumen, as we always see. It's the functionality. And I think we all have been trained to see that perfect angiographic appearance after the stent. But if you are going to be, and to my mind, again, years ago, yes, I will aim for that. Nowadays, the functionality is much more important. This is why we are using more and more drug-eluting balloon. And we're finding out that the results are as good as a stent. Yeah, we still need to prove that kind of with randomized trial and the comparison. There are quite a few of them ongoing. What level of comfort do you leave? I don't think anybody knows. It's all down to the operator themselves. But the message I want to give out is basically angiographic perfection is not synonymous with good long-term outcome. You could easily have a drug-eluting balloon and left with some residual disease and sometimes even a small dissection, and you find out the artery heals very well. and the long-term outcomes excellent, at least from what we are seeing on a day-to-day basis. So, you know, I think, but we have the armamentarium now, particularly with these kind of balloon, to be able to deal with many lesions, as well as the IVL and rotablation orbital. But again, don't think that putting a stent and making sure everything looks perfect angiographically is the ultimate goal. It should be for the functionality, and the less metal, the better.
Absolutely, I totally agree. So this is an important take-home message that you have to look at other parameters rather than angiographic images. Dr. Tey, any comments nowadays? What is your level of comfort? Are you okay? Do you find it easy to diagnose a calcified nodule? And I know we fear that but sometimes it only becomes obvious after you've done the initial inflation and so on, not immediately obvious even on IVUS.
In the calcified nodules, it's always have this poor clinical outcome, especially if the patient have an end-stage renal failure or the chronic kidney diseases. So if you do not prepare the lesion well, then with either the atherectomy or the IVL, sometimes they may need both of these, the atherectomy plus IVL, to improve the outcome. So if you do not prepare the lesion well, I will usually stop, and I agree with the Prof, is that the drug-coated balloon, perhaps you can help in this situation and then restudy the patient again. If you try to force and then using the very high pressure balloon and multiple device, the risk of this like perforations and also inadequate stent expansion resulting in this RSR or the stent thrombosis in the futures. So we do not look at the lesion itself, we have to treat the patients as a whole.
Okay, thank you very much. And on that note, I think on the OPN, we've not used OPN balloons in our hospital for some time already. So now that we've got better atherectomy and plug debulking facilities available. Dr. Liliya, any comments from your side about what is your level, I think?
Okay. I am totally agree about the preparation of calcified lesion. I will never put the stent when I have a lot of calcium, because there will no good result. And I like this this DCB technique. It's I prefer it because I don't like to leave a lot of metal at the vessel.
Right, I totally agree. Any comments? Anything else that tips and tricks that you might want to highlight? It appears that we all have IVUS easily at our disposal. So the next question is, if people do not have IVUS facilities, does that mean, what is the next best advice that you can give them in managing the sort of cases that we've discussed today? This is in regards to trying to reduce the amount of metal, trying to get the minimal amount of damage in the pursuit of your holy grail of angiographically perfect result. What advice do you have if you don't have this imaging, but you do have a POT balloon at least in your hospital? At least the most affordable. Yeah, Prof. Damras.
Yeah, I participate the PEPCAT-4 diabetic study that used the sequence please balloon. On that time, we don't have the OCT, we have only IVUS, but IVUS could not show exactly how much of the dissection flap. But for those who are DCB lover, I suggest you to follow with your OCT. And if it is a fibrotic plaque, calcified plaque, when you do DCB balloon, we try to encourage to use a little bit, let's say like 1/4 bigger DCB at lower pressure, and try to make sure that you don't have the dissection flap. Otherwise, it will be repeated like during the balloon period before stent. Because the patient may have the recoil or the abrupt closure during the day or during the night, during the evening. So for DCB lover, always use OCT to make sure that there is no major dissection, major flap left behind.
Right. Okay. That's a good teaching point. Dr. Mohaned, in a less privileged environment, let's just say,
Yeah, I'm
what
not
is your
sure.
advice?
Yeah, my advice is just I mean, try to learn how to size correctly, because sizing, started the webinar, I said my comment about the stents are excellent nowadays. And not every undersized or underexpanded stent will cause a problem. However, every problem with the stent is usually undersized or underexpanded. How do you get to kind of do this without imaging? It's quite difficult, but you do learn it, and you do see QCA is available. So you could use that to make sure that you prepare the lesion well. When you deploy your stent, you use it to the ideal way of deploying it, and hopefully that would give you a very good result on the long-term outcome. As for the drug-eluted balloon, yes, we are using these more and more, but I'm not as Damras is advocating. The problem with OCT will show you a lot of things that, especially after balloons, the dissections are everywhere, and that's how the balloon works, by dissecting the artery. I think angiographically, if it is less than grade 3, then you're probably quite okay. And we have left, from my experience with CTO, this is what we call the investment procedure. And I had many cases where you do an investment procedure and you come back 6 to 8 weeks later and you find the artery normal, and not normal, but open, and the flow is very good. So don't be afraid of leaving some minor dissection, because the artery will heal. If the flow is compromised, this is where you need to be worried, and maybe this is where you need to use a stent.
Right. So I'd like to take you up on that point that you raised, which is, and this is open to all the panelists, which is, in an ostial lesion, for example, in order to prepare the lesion well and to avoid surprises, which would you prefer as a first balloon? Would you prefer, cost, of course, is a consideration, but if you are in an ideal situation, would you prefer to use an NC balloon or semi-compliant balloon or scoring balloon straight up? Which one upfront is your, you think is the ideal situation that you should use?
Yeah. I'll tell you one thing, that I hardly ever use non-compliant balloon. I hardly ever use a semi-compliant balloon.
Okay.
99% of the cases, pre-dilatations with non-compliant balloon for me. The only time I use the semi-compliant if the balloon is not crossing. That's number one. For ostial lesion, I'm using more and more of a scoring balloon, which is the angiosculpt. What we find out, it does do the job without causing much dissection. Now, this is personal experience. I can't tell you any data to support this, but this is what I do. It does score because with the ostial lesion, often it's a little different from the normal one. There's a little bit more fibrosis, and of course you have the bifurcation, the carina. So the angiosculpt scoring balloon with that nitinol mesh on top of it works very well.
Okay, thank you very much. That's a good point. That's an important point. This is the ostial lesions are the ones that's challenging. Dr. Liliya, your experience in terms of ostial lesions, what would you prefer to use to start with?
I always start with NC balloon, with regular NC balloon, and after this, in ostial lesions, I like to use cutting balloons.
Okay, good point. Dr. Damras, your favorite to start out with?
Yeah, I use a semi-compliant balloon first, and then followed by whatever, cutting balloon, something, because sometimes ostial is fibrotic and it's difficult to cross initially with cutting balloon.
All right. So the crossability is important with the semi-compliant. Dr. Tey, your favorite default for initial opening?
For the ostial lesion, it's definitely a scoring balloon, but if there are some calcification, I may use this cutting balloon as well.
All right. So I think what's important is that the choice of device will depend on the nature of the lesion itself. And I think the lesion itself is best interrogated on different views and on various imaging modalities if you have available. But what is important is that regardless of whatever modalities you have, whatever facilities you have, you can use spot balloon anywhere. And I think once you, as Prof. Mohaned has mentioned, once you get the sizing correct, based on your different views, you should be able to, invariably get good results with confidence. And I think, and that's the most important message, because these lesions are now more complex. They are in younger people, and as I mentioned earlier on, the idea is to make it more precise and to use less metal. And we have seen that the pot balloon is a remarkable achievement in terms of its metal reduction and its performance. And I think that's what's the comforting part of it, that it's able to deliver consistently, at least from our experience, the results that we want. We've almost come to the end. I'd like to invite closing remarks from our esteemed panelists. Any take-home messages? And we are fortunate in that we have got about 500 people watching us, and I'm sure there will be some take-home messages that they'll welcome from all of you before we finish up for the day. Thank you. So, Prof. Damras, let's start with you. Your take-home message from today's discourses.
Yeah, thank you very much for all the panelists and all the audience. Today we learned the new device, a new indication for complex lesion. So you use POT, use it mindfully, and try to use it in a very effective way. I like Dr. Mohaned's suggestion. Without anything, you measure by QCA first. Don't use eyeball. Use QCA first and multiply by 1.1 to select the proper choice, and then follow step by step. And with all the technique, all the device that have been improved, we should achieve a better long-term result. And nowadays, when we talk about long-term result, we don't talk about just 6 months, 9 months, or 12 months. We have to talk about 3 years or 5 years compared to surgery. And thank you very much for all the faculty and all the audience.
Well said, well said. So 1.1 on the QCA, but measure nonetheless anyway. Dr. Tey, your take-home messages for our audience?
My take-home message for the audience, in particular, the left main bifurcation, it is a 011 or 001, 010. After your provisional stenting or this bifurcation stenting, I always recommend to make sure that you use this kissing balloon and followed by the POT to make sure the stent are all well opposed and maintain the carina without any shifting. And of course, the lesion preparation is always the most important thing before you put a stent. Otherwise, drug-coated balloon is my second option. If you can't prepare, you have a limitation in the devices to prepare the lesion back.
So good. So the drug-coated balloon as an option unless you can prepare the lesion quite well. And of course, the initial good results is important to avoid the subsequent complications and restenosis, as mentioned earlier on. So, Dr. Mohaned, and I apologize once again for mispronouncing your name, your closing remarks for the audience.
It's okay. It's all right. Well, I mean, just my message is that the POT balloon is quite helpful. It's not only, I don't want the audience just to think it's only for bifurcation. It's very, very, of course, one of the most important indication is in bifurcation to avoid affecting the carina and shifting it and so on, because it's precise and doesn't have a shoulder. But it could also be used when you are in an area where you don't want to cause any damage with the shoulder of any other balloon. So it's very precise and stops at the edge where you want it exactly, because there's no shoulder on it. And it can be used as a post-dilatation balloon in these cases. Proximal LAD or proximal circuit, you want to be precise and you don't want that shoulder to affect the artery. Of course, using imaging is important. If you don't have the imaging, QCA or something to help you to size correctly and prepare the lesion well before you put your stent in. Otherwise, you might be satisfied acutely, but in 3-4 months' time, you come back with problem with the stent, and that's what you don't want to be doing. So POT balloon does have a role, and I'm not saying that because we have used it, and now I'm quite pleased with how it's performing. And I use it in these cases, bifurcation when I'm doing the POT or any other artery that I need a precision post-dilatation without affecting the rest of the artery.
Thank you very much, Dr. Mohaned. Dr. Liliya?
I think that the POT balloon is the good dedicated device for the bifurcation, especially for proximal optimization, and especially at the left main. And I think that it can very simplifies the procedure for operator. And we have to use it more widely.
Right. So, even though you've recently used it, you're more confident in using this device. Excellent. So I think we've come to the end of the talk. My final comment is that I think if you don't have the pot balloon available, I think you should consider it in your armamentarium. And once again, it's been an honor for me to host this session together with our distinguished speakers, and to thank Rosman for a wonderful session. And I hope all of you out there will have take your messages to carry with you. And of course, once again, to consider the points that have been raised in your practice in interventional cardiology. Once again, thank you very much for spending time with us, and have a good day. Bye-bye.
Thank you. Bye-bye.
Thank you, everyone.
Thank you.
Thank you.
Bye-bye.
Bye-bye. Thank you.